Good morning everyone. So today's lecture is on Pediatric Endodontics Part 2. In this lecture we will be discussing about the pulpotomy, pulpectomy and the different materials that are used for it. So at the end of the lecture you will be able to explain the indications, the contraindications and the techniques of performing direct and indirect pulp capping, pulpotomy, pulpectomy, apexogenesis and apexification. So in this lecture we will be discussing about the pulpotomy and the pulpectomy, while in the subsequent lectures you will be having discussion on apexogenesis and apexification procedures. So moving on to what is pulpotomy. So it's a complete removal of the inflamed coronal portion of the dental pulp, followed by a placement of a suitable medicament or dressing that will promote the healing of the radicular pulp and preserve the vitality of the tooth. So we need to remove the coronal pulp which is inflamed, then place a suitable medicament on the inflamed pulp, or after amputation of the coronal pulp place a medicament on top of it, and this will promote the healing of the pulp which is there in the root area, and it will also preserve the vitality of the tooth. So moving on to the definition, pulpotomy is performed in a primary tooth with extensive caries but without evidence of radicular pathology, when caries removal result in a carious or mechanical pulp exposure. So we need to note down that the first most important thing is, when is pulpotomy performed? Pulpotomy is performed when there is a mechanical pulpal exposure, where you do not have any radicular pathology and the caries is only extending into the pulp, or it is close to the pulp but not involving the pulp. So how does it succeed in primary teeth? So a major question is, how does pulpotomy succeed in primary teeth? So it succeeds because of the high vascular and high potential for repair. High vascular region because the pulp chambers are large and the flow of blood is high, because of which the pulpotomy succeeds in primary tooth, and there is high potential for repair. So the rationale being, the radicular pulp tissue is healthy and can either heal after surgical amputation of the coronal pulp or be fixed or mummified. So what are the indications and contraindications of pulpotomy? So moving on to the indications, that is cariously exposed primary teeth, when there is retention is more advantageous than extraction. So a tooth which is carious but you have to retain the tooth for a longer time, so it is always better to go for a treatment like pulpotomy than extraction of the tooth. A tooth which is healthy and the periodontium also is healthy, in such cases you have to do pulpotomy. Pain if present, which is not spontaneous nor persist after the removal of the stimuli. So if the patient is giving history of pain which is not spontaneous and it does not persist after the removal of stimulus, and if the pain persists after the removal of stimulus, indicates that the inflammation has reached the root. If the tooth which is restorable, then again we do pulpotomy. Tooth with 2/3 of root length present is indicated for pulpotomy. So moving on to the contraindications, that is, if history of unprovoked toothache, if the patient is giving of history of pain which is unprovoked, then it will go for the other next extensive treatment than pulpotomy. If there is presence of sinus or swelling, that indicates the infection has reached the root area. That means we need to either do pulpectomy or extraction of the tooth. the evidence of necrotic or irreversibly damaged pulp, if there is uncontrolled hemorrhage from the pulp. So while doing the pulpotomy procedure, if there is uncontrolled pulpal hemorrhage, that itself indicates the inflammation of the radicular pulp. So in this case, we have to move on to the next extensive treatment than pulpotomy. So if there is periapical or bifurcation radiolucency, if we see, that again indicates that there is infection and inflammation which is reached in the furcation area. Then if there is pathologic resorption of the pulp, then pulpotomy is contraindicated. Primary root length less than 2/3 indicates the tooth is already resorbing, so it's better to avoid doing pulpotomy. And so in this case, pulpotomy is contraindicated. So in one of the first picture, what you can see, there is caries, but you can save the tooth. Only caries which is there, maybe if you do excavation, there might be pulpal exposure. So in this case, it is indicated. So in the third picture, you might be seeing there is inflammation or there is swelling or sinus opening, which indicates the tooth has become non-vital. So moving on to the classification of pulpotomy. Pulpotomy can be divided into vital pulpotomy or non-vital pulpotomy. So our treatment plan is based on the tooth vitality. If the tooth is has to undergo vital pulpotomy or non-vital pulpotomy. So in the vital pulpotomy, we have devitalization technique, we have preservation, we have regeneration. In devitalization, we have single sitting, that is Formocresol, electrosurgery, lasers, hypochlorite, and two sitting you have Gysi triopase, S-Lix formaldehyde, paraform devitalizing paste. In the preservation, you have the materials that are used are ferric sulphate and glutaraldehyde, and in the regeneration procedure we have MTA, then BMP and platelet rich fibrin. So under each we have different types of materials that are used. So in the non-vital pulpotomy technique, we have beechwood cresol and formocresol. So this is a very important classification. Based on it, you have to decide upon the treatment plan. So the ideal properties of medicament is it should be bactericidal. So whatever medicament we are using on the pulp, the amputated pulp should be bactericidal. It should be harmless to the pulp and the surrounding structures. So once you place the medicament on the pulp, amputated pulp, it should be harmless to the radicular pulp and the surrounding tooth structures. It should promote the healing of the radicular pulp, and it should not interfere with the physiological process of root resorption. So any medicament that you place on the tooth surface should not interfere with the physiological process of root resorption. So moving on to the devitalization, which is a single sitting. So the most commonly used over here is the formocresol. So formocresol consists of cresol, which is 35%, glycerol, which is 15%, formaldehyde 19%, water, which is 31%. So that dilution being 1:5 ratio. The application time is 4 minutes, and it is applied using a cotton pellet. So a cotton pellet is moistened with the formocresol and is applied on the amputated root, the pulp tissue for 4 minutes, and this will cause fixation or devitalization of the pulp tissue which is in contact with the medicament. So as you can see in the picture here, there is, once you place the medicament So after which the pulp tissue which is there in the root area, the first tissue that get fixation. So there is fixation of the pulp tissue. The next what we have is the coagulation necrosis, and at the end, that the apical region, you have the vital tissue. So what happens? Formocresol solution releases formaldehyde, and this diffuses through the pulp by combining with the cellular protein, and which fixes the tissue. So what I have already explained here itself, that once you apply formocresol, it releases formaldehyde, and this formaldehyde diffuses through the pulp and combines with the proteins to fix the tissue. So that formocresol has both cytotoxic, mutagenic and carcinogenic, and according to a study which was done in 2004, it is also known as a human carcinogen. So the dilution of 1:5 ratio, which is approximately 0.02 to 0.1 milligram. The full strength of formocresol is 0.013 milligram. According to WHO, it is 7.8 milligrams per day. So in pulpotomy, what you see here, first the coronal portion of the pulp tissue is removed. So once the coronal portion of the pulp tissue is removed, that was a cotton pellet impregnated with formocresol is placed on the amputated pulp stumps, and then for 4 minutes, after which the cotton is removed and zinc oxide eugenol is placed, on which a stainless steel crown is placed. So moving on to the next devitalization technique is the sodium hypochlorite material that is used. So which is anti microbial action, and it has the ability to dissolve the organic tissue, a formation of chloramines which interfere with cellular metabolism, and it has oxidative properties, that is produces lipids and fatty acid degeneration. It does, which is readily available, it is affordable, that is cheap, easy to handle, and it is used by most endodontics for decades. So the next in classification is the electrosurgical pulpotomy. So in electrosurgical pulpotomy, you use diodes which carbonizes and denatures the pulp tissue, produces a layer of coagulative necrosis. So a layer of coagulative necrosis which acts as a barrier between the lining based material and the healthy radicular tissue. So this electrosurgical pulpotomy denatures the pulp tissue, and this coagulative layer which is formed, it forms a barrier between the material, restorative material that we put, and the healthy pulp tissue. So the procedure being, it's initiated with the removal of the coronal pulp, after which electrodes are placed, not touching the pulp tissue but 1 to 2 mm above the tissue for 1 second, followed by a cool down for 5 seconds. And after completion of the electrosurgical procedure, you notice a dry and blackened pulp stump, after which reinforced zinc oxide eugenol mixture is placed, and it was then a stainless steel crown can be placed. Next is laser pulpotomy. So in laser pulpotomy, we use the laser ND-YAG laser, which emits infrared beam of a wavelength of 1064 nanometers, and which has a wide application for use in oral tissues. This laser creates a superficial zone of necrosis. Again, this laser also creates a superficial zone of coagulation necrosis that remains compatible to the underlying tissue, and then laser cleans up the pulp chamber. So the laser what we use, ND-YAG lasers, they clean up the pulp chamber in 10 to 20 seconds. So the result is what we see is that all soft tissue remain normal and reparative dentin formation is seen histologically. So moving on to the preservation type. Under the classification of vital pulpotomy, we move on to the preservation. So in preservation, we have ferric sulfate and glutaraldehyde. So ferric sulfate is the one which is most commonly used, and it's a coagulative hemostatic agent. It is used as an alternative to Formocresol by Fee. Fee was the person who used the ferric sulfate instead of Formocresol, and he used in pulpotomy in a concentration of 15.5% concentration. So the application time is less than that of Formocresol. So the application time here, what we see, is 15 seconds only, while that of Formocresol was 4 minutes. It is available in the solution form or gel form. And the ferric sulfate, what is the mechanism of action? That ferric sulfate form ferric iron protein complex, which when it comes in contact with blood, it forms a plug which occludes the capillary orifice. So when ferric sulfate comes in contact with the amputated pulp or the blood, it forms ferric iron protein complex, and this is a complex which forms a blood plug, or it forms a plug which occludes the capillary orifices. So again, in this ferric sulfate pulpotomy, if there is a caries which is involving or approximating the pulp, and the pulp is irreversibly inflamed pulp tissue, then a slow handpiece is used and the coronal pulp is amputated, after which a cotton pellet is moistened with ferric sulfate and placed on the amputated pulp for 15 seconds. After 15 seconds, you will notice that the pulp tissue has turned brownish black or brown, and then after which zinc oxide eugenol or reinforced zinc oxide eugenol cement can be used, on top of which a stainless steel crown can be placed. So glutaraldehyde again comes under the preservation, which is excellent antimicrobial agent. It causes less necrosis of the pulp tissue. It has superior fixative properties, low toxicity, and the inflammation is limited to the adjacent to the medicament, and there is no dentine bridge formation. Diffusibility is limited because of the large molecules, and so it does not penetrate the apex. So the advantage of glutaraldehyde is the molecule of glutaraldehyde is larger in size, so they are not able to penetrate beyond the apex, and it does not cause harm to the surrounding tissue or the tooth. And it also has a low toxicity, and the inflammation is limited to the area of the area where the medicament was placed. The next is calcium hydroxide, which was introduced by Hermann in the year 1930. So in this is complete or incomplete dentine bridges in the amputated pulp which are seen, which is classified as preservation or remineralization. So in calcium hydroxide can be classified into either the preservation group or in the regeneration or remineralization group. It has high alkalinity, that is of pH of 12, and internal resorption is seen because of the high pH. So calcium hydroxide is not recommended as pulpotomy medicament for the teeth because it causes internal resorption. Calcium hydroxide is not recommended as a pulpotomy medicament for the primary tooth. So why is the internal resorption which is seen after the placement of calcium hydroxide in while doing a pulpotomy of the deciduous teeth. It is because of the overstimulation of the undifferentiated pulpal cells. So what happens once you apply the calcium hydroxide on the pulp tissue? So there will be overstimulation of the undifferentiated pulp cells. So these undifferentiated pulp cells are the mesenchymal cells, which differentiate into osteoclasts. So these osteoclasts are the one which eats up the tooth structure, or it causes the resorption of the tooth structure. Alkalinity produces severe inflammation and subsequent metaplasia. Since the alkalinity of the calcium hydroxide is 12, so because of which it causes severe inflammation and subsequent metaplasia. And there is attraction and stimulation of the osteoclast. So osteoclast causes the bone or the tooth resorption. So the next what we have in the classification is under the regeneration. So in the under the regeneration we have mineral trioxide aggregate, which was introduced by Glutaraldehyde in the year 1995, and it is available in grey or white MTA, which is applied directly onto the amputated pulp. So there is lack of internal resorption, biocompatible, and has a good sealing ability. So the advantage of mineral trioxide aggregate is it does not cause internal resorption, which is biocompatible and has a good sealing ability. It helps in dentine bridge formation. So in the MTA, the steps are: once you amputate the coronal pulp, cotton is moistened with saline and it is placed on the amputated pulp to stop the bleeding. So once the bleeding stops, then the MTA is placed over the amputated pulp. So after the placement of the amputated pulp, then zinc oxide eugenol is placed, and after which a stainless steel crown can also be placed. So what are the diagnostic findings for pulpotomy? So the clinical examination, we see the size of the exposure, the nature and color of the hemorrhage expressed, the marginal ridge not intact as pulpal inflammation is earlier in proximal caries. So first is the size of exposure. We check for the size of exposure. If the size of exposure is small, then we go for the pulpotomy treatment. If the size of exposure is large and carious exposure, then we move on to the next treatment, that is the pulpectomy. The nature and the color of hemorrhage expressed. So if bleeding from the amputated pulp is dark red in color, indicates the pulp is inflamed, and even the continuous flow of blood, and if there is no clot formation, that also indicates that the inflammation has reached the radicular pulp. So the treatment of choice would be then converted from pulpotomy to pulpectomy. The marginal ridge, if it is not intact as in pulpal inflammation, then the treatment plan is again to pulpotomy and not a restoration, because the proximal caries, there are more chances of involvement of the pulp. Moving on to the radiographic examination. So how do we see which tooth will go for a pulpotomy treatment or pulpectomy treatment or extraction treatment? So in this picture, what you notice that the caries which is approximating pulp and not in the furcation area, not involving in the furcation area. So the first radiograph is indicated for pulpotomy treatment, while the second radiograph, as you can see, there is an extensive caries which is on the distal surface. There is radiolucency also in the furcation area. The radiolucency, what do you see? That means the caries is involving the roots also. So this tooth will go for extraction rather than a pulpotomy or a pulpectomy treatment. So, once after extraction, we move on to the next treatment, that is a space maintainer for this. So, moving on to the treatment steps and outline. So, first pre-operative radiographs are taken to diagnose if the and then or decide on a treatment plan. So, once the treatment plan is decided for pulpotomy, then local anesthesia is given to the patient, and after which a rubber dam application is done. After rubber dam application, the access opening and then removal of the coronal pulp to arrest the bleeding, after which there is placement of the medicament. Then is the placement of zinc oxide eugenol and the final restoration, and the post endodontic restoration with stainless steel crowns. So, here first we see that there is amputation of the coronal pulp. So, the first access opening is done, and after which the roof of the pulp chamber is removed, and then the coronal pulp is amputated. So, here as you can see, there is a rubber dam placement, and then the coronal there is access opening which is done. The next picture is the roof of the pulp chamber is removed, pulp tissue pulp is amputated, and this was the first picture, that is before the treatment. Pre-op picture, this is how it was. So, this was there was a mechanical exposure due to which it went for a pulpotomy treatment. So, the coronal pulp status. So, there is excision of the pulp tissue using. How do you remove the pulp tissue? There is you need to excise the pulp tissue by either using a spoon excavator or by using a hand by a air rotor. So, the pulp tissue is amputated at the orifice. So, the pulp tissue is amputated till the orifice of the canals, and hemorrhage must be pale red and easy to control. So, whatever bleeding what we see, it should be pale and easy to control. The pulp chamber is irrigated with saline, and after which a placement of a sterile cotton pellet which is saturated with saline is placed, and placed for 3 minutes, and hemostasis is achieved. So, once you see the hemostasis is achieved, then you place the medicament. Bleeding from the pulp tissue means there is improper removal of the tissue tags. So, application of a cotton pellet which is moistened with medicament, then removal of the cotton pellet and the pulp. So, once you place the clean the canal with saline, after which you take a moistened cotton pellet, moisten with the medicament, place it in the root stump. So, once the pulp stump appears blackish brown, then you restore the pulp chamber with zinc oxide eugenol, and the tooth is then prepared for stainless steel crown, or post endodontic treatment is the stainless steel crown that can be given to the patient. So, this is what the post-operative post endodontic treatment was done, that is a stainless steel crown has been given to the patient. So, the final restoration, the most effective long term restoration is a stainless steel crown. However, sometimes if the supporting enamel is still remaining, then we can give amalgam, or composite resin can also provide a functional alternative, especially when in the primary tooth which has a lifespan of 2 years or less. So, the final restoration is either a stainless steel crown, and if the tooth surface has enamel supporting it, then we can go for amalgam or a composite resin. Next, we move on to the mortal pulpotomy. So, mortal pulpotomy is ideally it's a non-vital teeth, so in which you have to do pulpectomy. So a non-vital pulpotomy is in case of non-negotiable root canals and limited patient cooperation. If the tooth is already non-vital and you have to do pulpotomy, this is in case if you have a non-negotiable, you cannot negotiate the root canals and the patient cooperation is very limited. So in the first appointment, what you do, necrotic pulp, coronal pulp is removed and the pulp chamber is irrigated with saline and it is dried with a cotton pellet. Then after which a medicament that is applied is the beechwood cresol. You have to seal the cavity for 1 to 2 weeks. Then in the second appointment, if the tooth is asymptomatic, the pulp chamber is filled with an aseptic antiseptic paste and the tooth is then restored with a stainless steel crown. So the next we have is Civec partial pulpotomy. So this is mostly done, this is done in young permanent tooth. So young permanent tooth is a tooth with in which the apex has not closed and it is a permanent tooth, in which calcium hydroxide pulpotomy can be it's also called as the calcium hydroxide pulpotomy. It was proposed by Majara and Civec and it is indicated in young permanent tooth where the pulp is exposed due to trauma. So if you have a patient who has come to you with an fracture, as you can see in this picture, the patient has a fracture of the 2-1 and due to which there is, even in the radiograph you can see the apex is open. So in this case what you have to do, you have to do Civec partial pulpotomy. The coronal pulp is amputated and then calcium hydroxide pulpotomy can be done. So this helps in to preserve the vitality of the radicular pulp and allow for the normal root closure. So this calcium hydroxide will help preserve the vitality of the radicular pulp and this in turn will help the closure of the roots. So now we move on to pulpectomy. Pulpectomy involves the complete removal of the roots. So in this in pulpotomy we were only partially removing, that is only the coronal pulp was being removed, while in pulpectomy you have to remove the coronal and radicular pulp tissue and then fill it with an obturating material which has resorption rate similar to that of the tooth. So pulpectomy involves removal of non-vital cariously exposed roof of the pulp chamber and the contents of the chamber in order to gain access to the root canals, which are debrided, enlarged and disinfected, followed by obturation with a resorbable material. According to AAPD, that is American Academy of Pediatric Dentistry, indicated in primary teeth carious pulp exposure, in which following coronal pulp amputation, the radicular pulp tissue exhibits clinical signs of hyperemia such as excessive hemorrhage, evidence of radicular pulp necrosis. So AAPD has indicated pulpectomy in primary teeth, in which after pulpal exposure and after pulpal exposure and you are amputating the coronal pulp, but the radicular pulp is extensively bleeding and there is signs of hyperemia, that is excessive hemorrhage from the bleeding from the amputated pulp stems. This gives an evidence of radicular pulp necrosis. So in this case we have to extirpate or remove the radicular portion of the pulp also. So the goal of pulpectomy is to maintain the primary teeth that otherwise be lost. So the main goal over here is to preserve the tooth structure in the oral cavity that would otherwise be lost because of the tooth destruction and extraction. So, the rationale is to gain access to the root canals, remove as much as dead and infected material as possible, and fill the root canals with a suitable material to maintain the primary tooth in a non-infected state. So, the main reason to do pulpectomy is so that you gain access to the root canals, remove any infection or material that is there in the root canals, debride it completely, place a suitable medicament that will promote the healing of the infection or infected tissue over there and not cause any infection further. So, the indication of pulpectomy is if the pain is spontaneous or persistent. If the patient gives history of pain which is spontaneous and persistent, irreversible inflammation extending to the radicular pulp, if the primary teeth is with necrotic pulp, tooth with evidence of furcation pathology. So, a tooth with evidence of furcation pathology is indicated for pulpectomy rather than pulpotomy. If there is presence of pus at the exposure site, that indicates there is inflammation and infection which is reached the radicular portion of the pulp. If there is presence of an abscess, fistula or sinus or non-vital primary tooth. So, in this picture you can see the carious lesion, that is the radiolucency is involving enamel, dentine and pulp. There is focal radiolucency that you can see. So, this indicates that the infection has not only reached the pulp in the coronal portion, but also reached the radicular portion of the in the furcation area. So, this tooth is indicated for pulpectomy. If the hemorrhage from the amputated site is dark, scanty and difficult to control or absent. So, depending on the hemorrhage, we can plan on doing pulpectomy or pulpotomy. If the hemorrhage from the amputation site is dark, then it indicates that the pulp tissue is radicular pulp tissue is inflamed. If hemorrhage is scanty, that the pulp tissue has become necrotic and difficult to control or absent. All these indicates that the pulp tissue, radicular pulp tissue has become necrotic. Planned for pulpotomy in excessive hemorrhage is encountered at the time of treatment. If you have planned for pulpotomy and there is excessive hemorrhage which is encountered during the procedure, time of the procedure, then it's preferable to be converted. The treatment plan has to be changed from pulpotomy to pulpectomy. The pulp destruction of a restorable primary second molar that occurs before the first permanent molar erupts. So, it is indicated if the pulp destruction of a primary second molar that occurs before the permanent first molars. If the primary teeth without successors, so in such case we have to preserve the primary teeth because the permanent successor is missing. Moving on to the contraindications of pulpectomy, a tooth that is not restorable. So, here in the picture itself we can see a tooth in which the mesial surface is, there is radiolucency involving enamel dentine pulp and there is resorption, what you see, there is focal radiolucency. So, this tooth cannot be saved. So, a tooth which is not restorable, it is contraindicated. So, the treatment plan for this tooth would be extraction. Next is pathological condition extending to the developing tooth bud. So, any pathological condition that is extending to the developing permanent tooth bud, it is contraindicated to do pulpectomy. So, less than 2/3 of the primary root structure which is remaining. If the root length is less than two-third, then pulpectomy is contraindicated. If there is internal resorption of the pulp chamber, then again pulpectomy is contraindicated. If there is any communication between the pulp chamber and the furcation area. So, here itself again you can see there might be a communication between the pulp chamber, the floor chamber and the furcation area. So, in such cases pulpectomy is contraindicated. So, the next treatment would be the extraction, and if the patient is having chronic illness like leukemia, rheumatic heart disease, chronic renal diseases, in such patients it is indicated to extract the tooth, rather do pulpectomy. So, in pulpectomy we have a single visit pulpectomy and a 2-visit pulpectomy. In single visit pulpectomy is done in inflamed but vital pulp. So, the pulp is inflamed but it is vital, and there is no symptoms of acute infection or swelling. If the patient shows symptoms of swelling and infection, then the treatment should be done in 2-visit rather single visit pulpectomy. If there is no active discharge of pus, it's contraindicated in single visit pulpectomy. 2-visit pulpectomy is done if there is an acute abscess, cellulitis and presence of active discharge of pus. So, in all these cases you have to do 2-visit pulpectomy. So, the 2-visit pulpectomy involves there is drainage of the abscess, and after which a Formocresol closed dressing is given, antibiotics are prescribed and the patient is recalled after 7 days. Once the tooth is asymptomatic, then further treatment is provided to the patient. So, in the first visit there is drainage of the abscess or any Formocresol dressing, and antibiotics are prescribed, and in the second visit if the tooth is asymptomatic, the treatment is carried on. So, step by step procedures for pulpectomy. So, in the first being pre-operative radiographs are taken, after which anesthesia. Once you decide on the treatment plan, then you anesthetize the tooth surface, anesthetize the soft tissue and surrounding areas, after which you place the rubber dam. After the rubber dam placement, you have to remove the carious dentine and do the access opening. After the access opening and pulp tissue extirpation, you need to determine the working length. After determination of the working length, you have to do chemomechanical preparation. Chemomechanical preparation is done, that is any pulp tissue which is remaining in the root area, radicular portion of the root, then that is extirpated. Cleaning is done with saline, and that is a chemomechanical preparation, and after which obturation with an obturating material which is for primary teeth is done, and the final restoration, which might be a stainless steel crown or a composite or amalgam, can be used. So, here in this picture you can see that the access opening has been done, the pulp chamber is de-roofed. After de-roofing, the pulp is still there, the pulp tissue is extirpated, working length is determined. So, these 3 files indicate the 3 different canals, after which it is obturated with a restorative with a obturating material, and then final restoration will be a stainless steel crown. So, here the obturation, as you can see, zinc oxide eugenol has been used, and it is placed in the root canals. There in this picture, in this radiograph, you can see some amount of radio opacity in the apical region. This shows that there is extrusion of the obturating material out of the apex. this is post-operative radiograph of after obturation. So what are the ideal root filling materials? So root canal filling materials or obturating materials. So the obturating material for primary teeth is different compared to that of the permanent tooth. So for primary teeth, the obturating material should be resorbable, that it should resorb with that of the tooth. It should be of similar it should have a similar resorption rate as that of the tooth itself. It should have antiseptic property and non-inflammatory and non-irritating to the underlying tooth gum. It should be radio opaque, easy for insertion and removal, and the most commonly used are the zinc oxide eugenol, Vitapex, Metapex, Endoflas. So here the restorable, the root filling material should be antiseptic, non-inflammatory, as you can see radio opacity. It should have to see the extent of the obturating material, and it should be easy to remove and easy for insertion. So the other pulpectomy or obturating materials are the walk-off paste, then the KRI paste, then you have Maisto paste, GPP paste, then you have Vitapex, Endoflas and zinc oxide eugenol. Vitapex is the commonest one that we use, that is it consists of iodoform, calcium hydroxide and silicone oil. Endoflas paste is triiodomethane, zinc oxide, calcium hydroxide, barium sulphate, liquid eugenol and para monochlorophenol. So zinc oxide eugenol paste, it's the most commonly used filling material, and it has some amount of advantages and disadvantages. So the advantages being, it is radio opaque material, has good plasticity, so more working time you have, it is cheaper and cost effective, it is less cytotoxic to the cells in direct or indirect contact. So it is less cytotoxic to the tissue around the area where the medicament is placed or the obturating material is placed, and it is effective antimicrobial agent. The disadvantage being underfilling. If there is underfilling or foreign body reaction due to overfilling and the slow rate of resorption. So the disadvantage of zinc oxide eugenol is it has a slower rate of resorption compared to that of the natural tooth. And if it is overfilled, then it has foreign body reactions which can be seen. Next in line we have is the Vitapex, is the most commonly used after zinc oxide eugenol. So this is another popular root canal filling material for primary teeth and is Vitapex, and it has a composition of calcium hydroxide, iodoform and silicone. So it comes in a pre-mixed paste which is enclosed in a syringe with an application nozzle. So this is what it appears as. So it is a yellowish color paste in a syringe with a nozzle, application nozzle which it comes. So the next material is the Endoflas. The Endoflas consists of triiodomethane, zinc oxide eugenol, calcium hydroxide, barium sulphate and iodine dibutyrylcresol with a liquid consisting of eugenol and para monochlorophenol. It is hydrophilic and can be used in mildly humid canals. The advantage of Endoflas is that it is hydrophilic and can be used in mildly humid canals. You do not have to dry the canal completely. It can be used in even mildly humid canals also. So, and the resorption is limited to excess of material which has extruded. So, the resorption is mostly of the material that is extruded beyond the apex. The resorption occurs there and does not occur within the canal, so it does not result in a hollow tube effect. So the hollow tube effect is what happens once you obturate the canal with the obturating material. The material resorbs at the same rate as that of the tooth, but not before that of the tooth. So if the obturating material resorbs before the tooth, it will create a hollow tube effect. Antibacterial, disinfectant, dentin tubules and hard to reach accessory canals that cannot be disinfected or cleansed mechanically. So Endoflas is antibacterial, it disinfects the canals and the dentinal tubules which are hard to reach by any other type of disinfected or cleansed mechanically. So the final restoration following pulpectomy is a stainless steel crown, composite restoration, glass ionomer restoration and open faced crowns. So the final restoration should be stainless steel crowns or the composite restorations. The success of pulpectomy depends on if there is no pathological mobility which is seen related to the tooth, which is treated, healthy appearance of the soft tissue. So if the soft tissue appears healthy, that indicates the success of pulpectomy. No sinus opening, no swelling indicates the healthy appearance of the soft tissue. Radiographic criteria is if there is no evidence of bone or root resorption, bifurcation, radiolucency which resolved in 6 to 12 months post-operatively. So once you take a radiograph of the tooth after 6 months and after 12 months post-operative and there is no evidence of bone or root resorption, indicates the success of pulpectomy. Or if there was a radiolucency which was seen in the bifurcation area which has resolved with time, indicates a success for the pulpectomy treated tooth. So moving on to the failure following pulpectomy. So if a tooth which is been pulpectomy treated and there is a pain, swelling or alveolar abscess, indicates the failure of the pulpectomy treatment. Then if there is over retention of the treated primary teeth, if the tooth there is over retention of the primary teeth, indicates there is a failure of the pulpectomy treatment. If there is deflection of the erupting succedaneous teeth, so if it's hindering the path of eruption, the permanent tooth deflects from its site or its way of eruption, then again there is a failure following pulpectomy. If there is over obturation of the root or under obturation of the root, indicates there is failure of pulpectomy, and periapical abscess also indicates the failure of pulpectomy. So moving on to the differences between the pulpectomy and pulpotomy. The technique being in pulpotomy, we remove the coronal portion of the pulp followed by application of medicament, while in pulpectomy only the coronal and the radicular portion of the pulp is removed. So from the picture itself, these two radiographs, what you see here, only the coronal portion of the pulp tissue is removed and the radicular portion is left intact. While in pulpectomy, we have to remove the coronal along with the radicular portion of the pulp. It is indicated in vital teeth. Pulpotomy is indicated in vital teeth where only coronal involvement is seen, absence of fistula, there is absence of spontaneous pain, absence of involvement of pulpal floor and absence of interradicular bone loss. So these are few indications where pulpotomy can be done. While pulpectomy, if the tooth is not vital, then pulpectomy is done. Coronal and radicular involvement, if there is presence of fistula or necrotic pulp, and presence of spontaneous pain, night pain and continuous pain is all indicated for pulpectomy. So moving on to the medicaments that can be used for pulpotomy and pulpectomy, which are different. For pulpotomy, you can use Formocresol, Ferric sulphate, MTA, while in pulpectomy, that is saline, chlorhexidine, sodium hypochlorite can be used. The obturating material is zinc oxide eugenol for pulpotomy, while in pulpectomy you have zinc oxide eugenol, Metapex or Metapex and Endoflas. So, this difference between the pulpotomy and pulpectomy gives a brief gist of the discussion that we have done now. So, these two radiographs are the post-operative radiographs after the treatment. So, this picture indicates what we see here is radio opacity in the coronal portion only. In both the tooth, what we see is radio opacity in the coronal portion. There is no radiolucency that we observe in the radicular portion, and there is no resorption also that we see. So, this radiograph indicates that the treatment that was done here in this patient was pulpotomy, where only the coronal portion of the pulp was removed, and after which a radiopaque material was placed, which is indicated to be zinc oxide eugenol. While the second radiograph, as you can see, the radio opacity which is involving the crown, and along with that is the root, that you see the radio opacity. So, this radiograph indicates that the treatment which was done for this tooth was pulpectomy. So, in this what has been done, the coronal and the radicular portion of the pulp tissue has been removed, after which an obturating material has been used to place to fill in the root canals along with the pulp chamber. So, we have reached the end of the lecture. In this lecture, we have discussed about the pulpotomy and pulpectomy procedures, the indication, the contraindication, the material used, and the diagnostic criteria for each. So, any discussions regarding this topic, please contact us for any queries. Thank you.